Inherited cardiac arrhythmias. So sudden cardiac death, the most common cause of death in adults under 65 is sudden cardiovascular death. It's characterized by ventricular fibrillation and the ventricle is beating rapidly and uncontrolled. Any inherited cardiomyopathy, arrhythmia, or aortopathy could result in sudden cardiac death as the first symptom. But we're going to be talking about the arrhythmias part of this. So arrhythmias are caused by abnormalities in ion channels, the transport of a number of different chemicals in the cardiac cells, including sodium, potassium, chloride, and calcium. But we're primarily going to be discussing sodium and potassium. The movement of these ions results in action potential that results in the heartbeat. Defects in the ion channels lead to poor channel conduction and abnormal timing that can result in arrhythmia. So long QT or prolonged QT syndrome is caused by a prolongation between the P to the T interval. So here's the contraction and here's the relaxation. And when this is prolonged, the heart forgets to beat again. And again, this can result in an abnormal rhythm. Long QT syndrome, there can be just arrhythmia or other symptoms include syncope, palpitations, cardiac arrest, and sudden cardiac death. Not a great first symptom. Over 30% of patients with long QT are asymptomatic, which means 30% of patients that have an abnormal gene for one of these, or an abnormal function, abnormal sequence to one of these genes, has no symptoms. Expanded family history is really important in the diagnosis and figuring out who else in the family is at risk. Age of onset can vary from 9 to 20, but can occur intrauterine and result in intrauterine fetal demise. It's inherited in a dominant fashion, and it occurs between 1 in 3,000 and 1 in 7,000 individuals. Langley-Nielsen is an uncommon form of long QT. This is inherited in a recessive fashion. And in addition to long QT, patients also have hearing loss. Romano-Ward is more typical. It's the name that we call prolonged QT or long QT. It's inherited in autosomal dominant fashion. And there are a number of genes that can result in this. As I've stated before, 70% of patients with a change in one of these genes will present with EKG abnormalities, but 30% have the abnormal gene are at risk of sudden death but have a normal EKG. So a normal EKG cannot rule out the presence of long QT. The most common mutation related to long QT are 3 genetic loci, including LQT1. We started naming things better, so LQT1 stands for long QT, the first gene we found. LQT2 is long QT, the second gene we found, and LQT3 is long QT, the third gene we found. LQT1 and LQT2 are potassium channel genes, and LQT3 is a sodium channel. Mutations of LQT1 are the least hazardous, with about a 30% chance of some type of cardiac event by age 40. Not all individuals, as I've stated, have an abnormal EKG. And this is actually an important slide. One is sometimes when people are swimming, it precipitates the arrhythmia. And so someone that actually drowns, a good swimmer in a pool, not going into Lake Michigan when the waves are too high, but they're sitting in a swimming pool and you find them at the bottom, they might have had an actual arrhythmia and their heart stopped, and that's why they drowned. So someone that knows how to swim and drowns in a calm swimming pool, it might be something like prolonged QT, and these are the kind of clues that you got to think about. But I want to talk about the genes. The LQT3, as we said, is a potassium gene. Gain of function results in long QT, or LQT3, of the gene SCN5A. Whereas the same gene loss of function in the transport of sodium results in something actually more severe known as Brugada syndrome or idiopathic ventricular fibrillation. So a gene has to work just right transporting that, either sodium or potassium. If it works too fast, in this case of the SCN5A, you end up with long QT, but if it works too slow, you end up with Brugada syndrome. The same is true for the potassium channel, the KCNQ1 and the KCNH2. In long QT1, which I said is the least severe of these, loss of function, unlike this one, loss of function results in long QT1, whereas gain of function, too much transport of potassium at this membrane, results in short QT. And the same is true of the other potassium channel, the KCNH2. Loss of function is long QT2 with the transport of potassium, whereas gain of function is short QT. This is actually a very large family history, and that was actually a true family history. And this individual, he was 63 at the time he presented with prolonged QT. And when you look at his family history, it was a very large Irish family, and he had a number of siblings. And this individual died at 86 of a cardiac, but he had two children. One had a ruptured aorta and one had a stroke. This one had, died of Hodgkin's lymphoma, but this woman never had a symptom. She had a daughter that died at 30 of sudden death and a son that had a daughter that died at 24 of sudden death. And this daughter that died at 30 had a baby that died at 15 months of sudden infant death. Here's another sudden infant death, or sudden death, excuse me. So when you look at this family, this is the first, he was actually the one of the youngest. And yet, if you look at this, it was actually not unusual in this family to go to a funeral because somebody, went out and drank too much and just didn't wake up in the morning. Not an alcoholic, just, she went out drinking and then, she just didn't wake up. And so it wasn't unusual in this family. Look at all these people in their 20s that just died in their sleep. This is a very concerning family history. Hindsight's 20/20, but again, he was affected with long QT, and then it turned out his son had it as well, and he didn't have any symptoms, but an ICD was placed. So this is one of the larger family histories that I've seen, but this is how it can look. So treatment, beta blockers to prevent symptoms, and sometimes, again, they need an ICD. There are a number of medications that can precipitate rhythm disturbances. These include antihistamines, erythromycin, Bactrim, and a lot of antipsychotic and antifungal medications. So the diagnosis prior to symptoms through genetic testing is important because sudden death could be the first symptom. So in conclusion, abnormalities in one of the three genes involved in the transport of sodium and potassium in the cardiac cells can result in prolonged QT or long QT syndrome. Clues in the family history include intrauterine fetal demise, sudden infant death, sudden death during adulthood, again, dying in your sleep when you're in your 20s or 30s. And patients are non-dysmorphic in most cases. The Langley-Nielsen had hearing loss, but that's in most cases not the case. So this concludes this brief module.